I don't know. I know they couldn't go to conferences.
Yeah, Amy, see this, it wouldn't be doing this unless the link to it on the commissioner's page was there.
I don't know.
No, it was something like that.
Status.
No, I think because it needs to be on, correct?
There's,
I know.
you know, people that.
There's a question about like.
No, there's a little icon.
And then their contact is, and so they have all this.
That's true, but it's live streaming now.
You know, they paid their own musicians and, you know, so that, I mean, that could be the same thing. You review all these papers, it's ready to go.
Oh, yeah.
They accept it, but it's just- they can't put it in. So you see authorship.
No, she said there's a report.
I guess-
So it's intellectual property. Great. I guess.
Well,
That just feels.
Oh, I wonder if he's on the bench. I go to the commissioners.
Yeah, that's what I'm saying, is like,
Yeah, it's on there.
probably needs to be more places that. That's why.
Yeah, I don't usually put that on the FAB webpage, but it is on the,
And there's nobody on.
it's on the live stream.
Commissioner. But that would be.
Slide through when it should be.
Good point. Like, the non-government first publish an MSWR, but it never said that MSWR is frozen.
Yeah, we can go. We're streaming.
All right, guys, we're gonna start the meeting now. Thank you.
Right after this.
Thanks for everyone for coming. We'll introduce everyone ourselves. Myself, I'm Rob Ross. I'm a family doctor. Director of Academics and Research at St. Charles. Colleen, we'll go this way, counterclockwise. Why not?
I'm Colleen Sinski, Vice Chair of PHAB, and when I'm not doing this, I run a small organization here in town that's addressing homelessness through supportive housing.
I'm Tammy Pike, Director of Health Services for Birmingham Schools. Yeah, Bachelor Program Manager for Communicable Disease Prevention and Management.
Amy Burrows, Deschutes County Public Health Admin Assistant.
Kelly Coyle, Public Health Nurse with Communicable Disease for Deschutes County.
Rich Fawcett, Deschutes County Health Officer, and Infectious Disease Physician.
Erin Fitzpatrick, FAB member. I'm Sherry Lovelace, Senior Director of Clinical Ops for Dentistry in FAB work.
My name is Sarah Barron. I work at Central Oregon Community College as a public health professor.
Tom Kuhn, I'm the FAB coordinator here at Public Health.
Are there folks on the streaming that need to introduce? Lindsay?
Hi, everyone. Lindsay Atagi, Director for Central Oregon CCO with Pacific Source, attending virtually home with a sick kiddo. One of these days I'll make it in person, but appreciate being able to attend virtually. Thank you.
Well, thanks for coming. Anyone else? Virtually? Okay. If not, did everyone have a chance to read the March minutes? If so, can we get a motion in a second?
I'll make a motion.
Second. Thanks a lot. Any discussion, changes, or guess not. Anyone disagree with the minutes of the March meeting? All right. We approved those meeting minutes then. Announcements and updates. Is anyone from the public online?
No.
No. Okay, done with that. How about announcements or updates from FAB members? Anything new and exciting in the public health world, education world, otherwise?
I'll throw it out there. Thank you for the people who, this is Sarah Lindsay from Central Oregon Community College. Thank you to the people who had the students interview them for the public health introduction class, Introduction to Public Health Professionals. There are about 5 or 6 people that they reached out to and they put together these really pretty presentations that I kind of want to share. I went back and I said, I'm going to share yours. How do you feel about it? So if you're interested in seeing those, there's a spotlighted different. If anyone wants to share their experience, how was it?
It was great. A long time, and I reached out to Sarah because I was like, I started my career in public health, but I'm a dental hygienist, and I said, so I wasn't sure I made reach out, and if there was someone who wanted to be a dental hygienist, and she's like, that's the reason I reached out to you, and so she got to hear my journey, how it started.
Cool.
So just trying to cross all those different, have a lot of people exploring health careers. So anyway, I'm excited about that. I'm still on track on trying to bring that into the high schools. And so my goal is, our goal is to get more public health spotlights out there. So thank you for volunteering. I think I need a lot of thank you notes because a whole bunch of people from public health did it too. Yeah, again, so yeah, I'm dropping more thank you notes in there. So big thank you.
Excellent. Any other announcements or items of interest from anyone?
You guys aren't aware, there's House Bill 2676 is happening for dentist and dental hygiene license compact. So that would allow Oregon to go deeper in the compact out of state providers easier access. Oregon has a pretty broad. We kind of really expedite for dental dentists and dental hygiene, but it's still that come in. Well, so that's something that's gonna likely move forward and there's a work session today around it. They'll likely move forward in place in 2026.
So it would increase reciprocity?
Yeah, so anybody that's a part of the compact, like wherever your license, you'd have one, and it would allow you to get licensure in one of those compact member states. I think there doesn't sound also on it. So you still have to pay the state licensure. There's a whole bunch of layers to it,
But it's not a big policy. Yeah, all right. Sounds cool.
Anyone else? Okay, so tomorrow, Colleen, Paul, and myself are going to the commissioners meeting to see if we can get our bylaws approved and officially stamped as official. So, Tom, any other?
Yeah, just that, we update the bylaws usually anywhere from 3 to 5 years approximately. And they always have to go through the commissioners, but we also take this opportunity to interact with the commissioners, share a little bit about what PHAB's been up to and make a plug for public health modernization funding and things like that. So yeah, looking forward to it. And we approved the bylaws at our last meeting and then county legal did a review as well. So they just made some grammatical tweaks, but it's pretty much ready to go unless Colleen's one at it.
No, I was wrong.
It is in there? Okay, I thought so. I thought I captured it at the last meeting. And I was like, oh, shoot, I hope I got it. Okay. So anyways, yeah, we'll be there tomorrow at schedule at 11:30. You can watch the live stream on the commissioner's website if you're interested. And yeah, nice to have some FaceTime.
Were there any major changes?
It was in membership, the seats, like we were assigning specific seats to the members. That was the most major part of it.
Most of it was housekeeping and grammatical and other stuff, other than the seat membership.
Yeah, and also some membership expectations we put in there too.
Something like commissioners would probably have on their mind. I don't know whether they're going to what 5. Is that-
I'm sorry?
The commissioners are going to change to what 5? What was this?
No, we're talking about the PHAB membership.
Right, but I'm just saying, you presented to the commissioners, right?
Yeah.
So, their mind is membership too, because they're, I don't know when it changes, but it's gonna be, I think.
That's not for a little while before that.
Oh, is that right? We're gonna have
Yeah,
5.
got voted in, I don't know.
Yeah, that's interesting.
But I think the current conversation is around districting. So that, I don't think that it's on the agenda for tomorrow, but it is on like current meeting agendas and part of the conversation. Whether they would all be at large broadly or whether it would be districted.
They're not districted now, I mean, they're.
Yeah.
all part of this.
Well, we won't be talking about that.
Yeah.
Suggestions.
Yeah. Um,
And legislative update.
Yeah, I don't have a ton since the last meeting. We've done quite a bit of advocacy, in support of obviously public health modernization funding. Letters of support from the commissioners and from PHAB went in for that. Also, we had letters from the commissioners and PHAB from Senate Bill 702. The, ban on flavored inhalant products and devices. And that one's still moving through, and may need some more work because there's a lot of opposition to it. The one newer thing I have to update is House Bill 2954, which is the prevention funding bill. This would provide every health district with some funds to provide some prevention and addiction services. And that one hadn't had a work session scheduled, or excuse me, a public hearing scheduled yet. And luckily it is gonna have a public hearing either on April 9th or the 16th. And also the conference of local health officials is putting a panel together that they're hoping can speak before some of the committee members. And that's gonna happen sometime in the next couple of weeks. And Heather Keisner, our director, will be on that panel. So I just wanna give an update. That bill is still going along. We were getting a little worried because they hadn't had a public hearing. And the deadline for public hearings for most bills is April 9th. And if you don't have a public hearing by April 9th, then your bill is dead. But I guess because this is in a joint committee, that there's a longer deadline. So the meeting could happen on April 16th. That's still fine. So anyways, but a lot of the bills on my watch list are going to drop off next week. So, which happens every session. But yeah, that's pretty much the major things, the prevention funding that we're still moving. So. fingers crossed.
Can you speak also to the federal level that's happening around public health? I mean, I'm seeing so much in the news. Just curious, like what threats to the Deschutes County Public Health budget, if any, are being projected or?
Yeah, and Heather couldn't make it to the meeting today because she's downtown, so.
I think we feel like it's gonna be connected with or filtered down from OHA, so.
Kind of a buffer?
Yeah, I think things are sort of pseudo stable. There's nothing major, but gave us a bit of an update on Friday. She was out for just half a day or something, but I didn't read it carefully, but.
So, do you mind speaking a little bit?
Sorry about that. Yeah, I think a lot of what will happen locally in Oregon is probably gonna be connected with what happens with OHA. So, the main thing, there's some retirements coming up, C-SLAC, for instance, so those are really probably not directly related to what's happening in Washington, DC or the CDC. So, I think it's still to be determined, but we're, going to be watching very carefully what happens in the state.
Yeah, they did. I guess the one thing I didn't mention or forgot about was COVID funding was ceased. So we had to, do a little work in our budgets to adjust for that, but it was only for the last 3 months of this fiscal year. So,
Okay.
anyway, so we had a little work there, but nothing major otherwise.
Okay.
Is the CDC still reporting on measles accurately or not? Do you know?
They are reporting. I don't know how timely it is exactly. I think it's interesting what it would look like at the Texas State Health Department, how they keep up and how they interact with CDC.
Right.
Well, it's just, to be kind of scrutinized for efficiency at the same time you have a, epidemic spreading into other states even, seems almost untenable. So I don't know. I imagine there's still efforts towards that, and I don't think it's all about vitamin A, I hope so.
I thought it was cod liver oil, or is that something else?
I didn't hear that, now that RFK Junior has talked about, there's no specific therapies, but this, but that, vitamin A is one of those papers that he himself reviewed and thought it might be helpful. It's still expanding, so. But I think one thing would be interesting to keep to, update the rate of new cases, just perhaps the rate is slowing a little bit, I don't know. What worries me is the lack of identification. You know, that there are cases that are not being reported quickly, so I don't know, but I think, I hate to say, but I think the rate of new cases has slowed a little bit, it's still growing.
Right. Health heroes.
Yeah, just quick Health Heroes update. Our request for nominations for the Health Heroes Award went out about a week and a half ago from Central Oregon Health Council. Actually, they sent two out because the first one came with a PDF application form only when it was supposed to be a Word form. So then they followed up with a Word document to make it easier for some people to fill out. And I'm happy to say we already have 3 individual nominees, so that's great. But 0 organization nominees. So that's the area we'll have to recruit for at this time. And still planning on holding the award ceremony in the early June meeting, like we've been doing. It's been pretty successful. So hoping to do that again this year. Yeah.
Cool. So if anyone has any organizations that they'd like to.
Or know people that you can get to
or
nominate.
people
Yeah, 'cause we can't
that to nominate.
Yeah,
Yeah, I think FAB members can nominate.
can we now?
Whatever's, I honestly, it says in the application sheet with the
Okay,
criteria. I
I'll
can't remember.
read it, I'll read it.
Yeah, there's criteria around it.
You can't win.
FAB members can win, yes. But I'm pretty sure you can nominate somebody.
Okay,
But it usually looks a little better if it's somebody from the community
yeah.
nominating
Okay.
versus a FAB member, so,
Makes sense.
yeah.
How many do you have? Each?
2 awards, individual and organization.
All right, Rick and Kelly. Plague presentation, that sounds awesome. Bubonic or bubonic plague or just plague in general?
Kind of, all different forms, I guess.
Yes. Yersinia pestis, put it that way.
Oh, Yersinia pestis, okay,
Yes.
yeah, so bubonic.
I have to see how my PowerPoint, the color didn't, it's not a big deal, but.
Thank
It's a
you.
different font and a different color.
And that's how it came out. So you can just use these 2 buttons.
Okay. Up and down.
Yes. Lindsay, can you see that presentation okay?
I can. Thank you so much.
Okay, thanks.
Thanks for inviting us. To speak. I'm Rich Fawcett. I'm an infectious disease physician in Bend and Redmond primarily. And I'm the health officer, and this is a case that our health department was very involved with back in the beginning of 2024. I remember Kelly, one of our dedicated public health nurses, which here today, was on call. It was a Friday. It's always a Friday when these things happen. Friday was really, I think, the 3rd hospital day for the patient anyway, but that's kind of when we were notified by the labs. So it's kind of nice since we worked with the hospitals a lot. There was a lot of community work that came under this, mainly towards deciding how contagious the patient was and how we should try to interrupt any potential transmission to contact. So that's one of our biggest responsibilities at the health department. So, these are rare cases, as you might imagine. We had one about 12 years ago I believe that was a Crook County resident, but we were very involved with that as well. So, last year, so or EPI, which is every spring, usually in April. That was about 2.5 months after we were sort of finished with our investigation. And I know because of the way the media is now, I got a call from a reporter in New York City, one from New Jersey, one from Michigan. It's kind of funny how things spread so fast. So I'll just say a very funny story. This is just off the cuff, but Eric Money, if you know him, longtime environmental health director, said he had been away end of January, this is 2024, and he was flying back to Redmond. It was at the Denver International Airport, and it was like in the Denver paper about a case of plague in Redmond, Oregon, Deschutes County, and he had heard about it perfectly, but he was kind of looking over the person's shoulder who was talking to her. If these are older women talking about this case, my oh my, look at this plague in Oregon, So I mean, it's amazing how fast news events spread. And really, fortunately, there was really just 2 sick individuals, a patient who I'll talk about and his pet cat, and really nobody else became sick, which is really a fortunate thing. I don't know it's all to our credit or the credit of hospital epidemiology. But typically we don't see this now as epidemic or pandemic. It's usually very sporadic. So, right. So we're gonna talk a little bit about the case itself. Just that's my role in this presentation. I'm presenting with Dr. DeBess, who's the state veterinarian. He's been at OHA for a long time, and we're putting our slides together this week. I think our deadline is next Friday. So I don't have his part of the talk, but I know what he's going to present. So if you have questions, I can try to speak to some of the information he was going to present. So this is the case. I'm sorry about how do I advance down below so the whole slide gets on there? I don't know. For me, it comes up fine, but I guess we'll see if every time I hit down, it's going to go to the next slide. I'm not sure you can see the bottom. Suggestion.
Well, it's kind of hard to read from back here anyways, so.
Yeah, okay. All right. Is there a way I can go down here?
Yeah, click the down button.
Well, but here's what happens with the down button. I go to the next slide. So
It goes to the next slide.
Yeah, it's in slideshow view right now.
But is that the next one? Go down.
I mean, we can try shrinking the slides.
I think it's kind of hard to say that.
I think we gotta get out of it. Get out.
That's slideshow.
Okay.
Yeah, so now you just.
Usually,
So you have to just scroll this way.
Here, let me try something.
You have to scroll this way. You have to scroll.
Other side like this. I was gonna see if you can shrink the.
Yeah, you have to scroll.
You want to just do it like that, Dr. Foster?
Yeah, you have to scroll like
How do
real.
I scroll? Scroll with
You have to
just
scroll like,
mouse, right?
yeah, very.
On the side. Okay, yeah, I got
Very
it.
little by little,
No, that's good. I
otherwise
should've
then
thought that.
it goes to the other.
Not happy with that. Okay, thank you. Oh, wow. Maybe. Yeah, perfect. Let me use that up there. Okay. All right, great. Okay, so this is a 73-year-old man, resides in Central Oregon, a history of mild chronic obstructive pulmonary disease, emphysema, mild or asymptomatic coronary disease, hypertension, and he presented to a Central Oregon Emergency Department at Redwood. It was late January 2024, had a 4-day history of a very painful, quite raised erythematous solitary skin lesion over his distal right volar forearm. over that 4-day period, he also developed some erythema that mainly ended up in his axillary region with swelling and pain in the right axilla, really from a lymphadenitis once he came in to be seen. Significant additional history for this gentleman was that he had accidentally cut his right second finger on a kitchen knife about 24 hours before he noticed this lesion on his forearm. He actually came in to an urgent care the same day and had it sutured. So that was 24 hours before the lesion on his distal forearm appeared. I didn't see a good exam to see if there was a direct connection anatomically to the index finger down through the tendon to where it was close to the wrist, just below the wrist where the lesion appeared. But when he presented to the ER, his sutures were healing well. His finger was doing quite well. So the other thing is that his pet cat had this severe illness that was diagnosed by his vet about 1 week prior to the appearance of the lesion over his forearm. So I think I talked a little bit about him going to an urgent care. Again, that was 1 day before the lesion appeared. He didn't get antibiotics, just the tetanus booster. And the finger, by the time he finally came into the ER, which was 5 days after the injury to the finger, the index finger was healing and looked just fine. It wasn't inflamed, it wasn't even painful. Additional history was that his cat had gone back to the veterinarian about 3 days prior to the appearance of his forearm lesion, and the cat was hospitalized and got antibiotic treatment and had developed a neck abscess. We're not sure which antibiotic that was given to the cat. So just prior to the appearance of his forearm lesion, the patient had brought his cat home from the vet hospital. So the cat had been staying overnight for drainage of this neck abscess, brought the cat home. So he was managing the cat's abscess and the cat's drain at home right about the time that this lesion appeared on his right forearm. So the cat was treated with this neck wound drainage antibiotics. The infection was not known to the veterinarian. I don't even know if they did any cultures there. The veterinarian really didn't think about something like a zoonotic infection like Yersinia pestis. And there was the story that I think presumed by somebody, perhaps the patient, that the cat had been in an altercation with a raccoon or porcupine. Some records say porcupine, some say raccoon. In any case, the cat fell ill a week or longer prior to the appearance of the forearm lesion. So there's about a week apart between the cat's illness and the first signs of the patient's illness. So upon presentation in the emergency department, apart from the right upper extremity symptoms, the forearm and the axillary pain and swelling, the patient complained of chills, sweats, severe fatigue, orthostatic dizziness, meaning he felt dizzy when he stood up, and nausea, but he didn't have any fever, either subjectively or measured. There in the ER, the initial temperature was normal, 36.9 degrees Celsius. Blood pressure was high normal. Room air oxygen saturation was normal, 96%. On exam, this forearm lesion was on the volar side, so on the inside, basically, the flexor side. It was about 2 centimeters in diameter, quite raised and quite tender. There's no drainage from the lesion. And he had redness up in the axillary area, which was quite tender to the point where it was hard for him to lie on his right side. Initial blood work that was done included CBC, which showed a white blood cell count that was just above normal, 10.1. He's somebody with COPD who had smoked in the past, so his baseline hematocrit was about 50. That's where it was, 51%. He was thrombocytopenic. His platelet count was 61,000. That's quite low. Normal is about 150, 140. And at just trivial elevation of one of the liver function tests, the AST. The other liver function tests were normal. His kidney function was also normal creatinine. initial chest X-ray showed these linear markings that were thought to be atelectasis or lung compression at the lung bases. He also had a Doppler ultrasound of his right arm that showed this non-occlusive, so small, deep venous thrombosis in the subclavian vein. And then there was a superficial thrombosis in the basilic vein. The basilic vein was probably in communication with the axillary area. So he was started in the emergency department on 2 IV antibiotics, ceftriaxone, metronidazole. Blood cultures were drawn before the antibiotics were administered as appropriate. He was admitted by the hospitals, and for whatever reason, I think there was some discussion about the differential diagnosis, but the antibiotics were changed to ampicillin sulbactam. And the patient was about the same the first hospital day. So the ER, and then the first hospital the next day. Still no fever, but was not feeling well. Platelets had decreased further to 55,000. It was on that day, the first full hospital day, that his oxygen saturation decreased to 89%, and he was a little bit tachypnic. He got a CT pulmonary angiogram, which showed a possible consolidation. A small area in the right upper lobe was felt by the radiologist to be non-specific, so it could be pneumonia, it could be an early lung mass, very, very non-specific. Was not seen on the chest X-ray. So later on that first full hospital day, the blood cultures did turn positive for a gram-negative rod, 1 out of 2 blood culture sets. So this was the first clue that he had a sepsis presentation, or meaning that his symptoms were related to a bacteremia, a bacteria in the blood. The lab worked pretty diligently to figure out what this was. It wasn't a typical gram-negative rod like an E. coli or a Klebsiella. But you know, their testing took some time to figure that this was even a Yersinia type of organism. Anyway, his oxygenation worsened a bit by hospital day number 2. He was a more tachypnic, respiratory at 24. His white blood cell count had increased to 13.7 by hospital day number 3. And on hospital number 3, he was seen in consultation by infectious diseases. Part of the delay probably was the weekend. I think that it was Monday morning or maybe Sunday, actually, that my partner saw him in Redmond in consultation. So right about the time that my partner saw him, the lab knew that the organism was a Yersinia type organism. So there's not that many things. There's Yersinia enterocolitica, which is pretty much a gastrointestinal pathogen that's reportable, but really that presents with abdominal pain, diarrhea, really never any kind of skin presentation, cellulitis, lymphadenitis. That's not something you see with Yersinia enterocolitica. So with this history of his sick cat, et cetera, I think the suspicion on hospital number 3 for plague was much higher. And that kind of drove her recommendations to change the antibiotics to gentamicin. 5 milligrams per kilogram, fairly high dose IV, along with IV levofloxacin. So her feeling was that this patient had a bubo, so that this axillary lymph node was very tender. It was a lymphadenitis. There may be a cutoff in the literature about when you can call it a bubo, but typically, if it's the size of a golf ball or a ping pong ball or bigger, is usually what bubos are. This was very easy to palpate. It was very tender. It really seemed to be directly anatomically related to the lesion on the forearm, which had redness and swelling. So the most common types of human plague are bubonic, which means lymphadenitis, large lymphadenitis presentation. The other one that's fairly common is septicemic. And in this case, really, it was felt that he developed skin sores and a lymphadenitis of bubo, which then led to secondary sepsis or spread to the blood. So both bubonic and septicemic together, probably in that order. Now, one of the important points here was that this patient, although he had a history of COPD, he was not on oxygen at home, but he required oxygen in the hospital. He had a possible infiltrate, very subtle on the chest CT. So whether or not then he developed kind of a tertiary or hematogenous spread to the lung, and then, a secondary, therefore pulmonic plague is really the question. So if we had a pulmonary plague, that's a condition that's much, much more contagious with droplet spread. So the hospital was pretty careful about this. He probably didn't have that in retrospect. But again, he was requiring more oxygen. He had a small abnormality on the CT. And so at the time that he required oxygen, which was the second hospital day, they decided they would count back about a day for everybody that was exposed to without isolation precautions. So that's kind of how they decided how to do contact investigation in the hospital. So then he did very well once he was switched to this combination of gentamicin and levofloxacin. When he followed up about 8 days later, he was feeling terrific. He had some residual swelling in there, hardly any tenderness, some mild fatigue. However, his cat didn't do so well, and the cat had actually passed away on his second hospital day. The state health department was able to procure the cat, and liver and spleen of the cat were sent to CDC and tested positive for Yersinia pestis by PCR. Of course, the blood culture in the middle of this hospital stay was confirmed as Yersinia pestis as well. I don't know for sure if they compared the two organisms, but by inference, they've got to be the same organism. It would be too weird for them to be two different strains. Yeah. So that's kind of the case report. We were involved basically on hospital day number 3. I guess that was actually a Friday. So that's infectious disease, public health and infectious disease got involved a little late in this case, to be honest. But this is a tough gentleman who ended up doing very well. So just to review very quickly, the forms of human plague: bubonic, septicemic, and pneumonic or pulmonary, lung infection. Again, we feel this was primarily a case of bubonic plague because it presented with skin sores with drainage to a large lymph node and lymphadenitis, and then was a secondary septicemic case because it spread from the infected skin and lymph node into the blood. Whether or not he really had pneumonic plague as well, it probably didn't, but I think to be cautious, we decided that he could have had that in the middle of this course of therapy. There was some delay, of course, in getting him on the right treatment. So he, maybe he would never have had respiratory symptoms at all had he gotten onto gentamicin levofloxacin from the get-go. It's hard to know. So he sort of had all three, but primarily his first presentation was with bubonic form. And so that's the idea of the overlap combined forms. The only other thing I wanted to mention was just to keep in mind that with human plague, and this came out a lot when we were interacting with the press. I mean, I think Friday we knew we had a case. It wasn't confirmed in the lab really until Sunday or Monday. So Monday there was sort of an official report of the case. And by Tuesday, for the next week or week and a half, we were doing interviews almost every day. There's still this idea that plague, whether it's bubonic or septicemic, is something that causes epidemics and needs to be investigated and prophylaxed and treated aggressively, because it will result in an epidemic in your region. It may not spread to all of Europe or all of America, but certainly Central Oregon is probably going to have hospitals full of people with the plague, and that just doesn't have. It's really now a sporadic case. It's not an epidemic or a pandemic or even an outbreak, really. In fact, our last case was not an outbreak. They had one in Lake County, which was one person. There was another sick person in the same family, probably exposed to the same rodent source. In any case, so it's really sporadic. Of course, that really has to do with public sanitation. We don't have huge rat populations, and we can have flea control even with our pets. We don't have a lot of fleas really in Central Oregon, thankfully. The other thing that was brought out by the OHA, actually, which is interesting, is that they looked back. There are 18 cases of human plague reported in the Pacific Northwest over the past 90 years. And this was really the one that was in the sort of dead of winter, the only January case really that we had. And looking back at January 2024, it's a very warm January. So some thought that maybe we can see plague, even during the colder months, which is kind of unusual. So I think I'll hold questions until after I give Kelly, the public health nurse, a chance to talk about the case, if that's all right. Thanks.
You press the side arrow to advance it, is that?
Oh, sorry. Yeah, you probably, you can. I
This
do
or
the
do you
down,
hit this?
down,
The
down,
down?
that's-
Oh, okay.
But you don't, if you need to, you can use the mouse.
Oh, this is- Oh, okay.
Yeah, if you don't, you probably don't. It looks like you have a
Mine's
slide
good.
going
I
through
really
the
pretty
so
easy.
just Next slide.
Okay, thank you. Okay, so I cover CD, general CD, about once a week or whenever the other CD nurse is on vacation or sick or something like that. So I usually do, congregate settings, outbreaks and stuff. So anyway, so it was kind of just lucky, I guess, that I was on that day. But luckily it was kind of early in the day, but St. Charles Infection Prevention called and said, you know, we've got this person who has plague. And so, so the first step, I'll just go through this timeline of what happens. First thing was, you know, you pull the Oregon investigative guidelines for the disease. And so I just reviewed through that really quick. And with the information that I'd gotten from the IP nurse over there. And then I, you know, printed off the chart and, and luckily Dr. Fawcett was in the office that day too. It all kind of clicked. So I was able to go over and show him. We're like, oh boy. So Dr. Fawcett reviewed the case of the hospital record. We were able to pull him up in Epic and all that. And then comparing the patient's chart with the investigative guidelines, determined that yes, he does meet case definition as a case. And then the important thing was step 4 there. Dr. Fawcett determined the status of the case's infection, and based on that, we developed criteria for the designation of a contact. So that was where, like Dr. Fawcett was saying, it was, you know, it looked like he was at the bubo stage, which was really great because that way we didn't have people in the community who would have been exposed to him really, because it would be very hard to have that through some kind of contact of pus, which he didn't have happening before he was in the hospital. He didn't have, so that was nice. So we determined our criteria for a contact in the community. So then I called up St. Charles, talked to the IP nurse, told her, yes, does meet the criteria for this patient to be a plague patient, and then discussed with their IP department, and then they talked to their IP docs and medical director about what they were going to do. And so then they proceeded with identifying and treating any staff contacts. And then they did their thing, like Dr. Fawcett was saying, where they determined to be on the safe side, that just to be on the safe side, they would go ahead and prophylax or treat the staff who were exposed to him before they put him into isolation when his respiratory symptoms started to escalate a little bit. So then we called up the OHA epidemiologist and let them know what was going on. And so they were, of course, had a lot going on, you know, about what next steps would be and this and that, and let them know also about the cat situation. But we didn't have a lot of details at that time. The only information I really had was from the chart and then from what the IP nurse had told us. So the case was not in the ICU. He was on the medical floor and he was sick, but he was, you know, he was awake. You know, I called the nurse on the floor and she was like, yeah, he's awake. He's real chatty. So, you know, yeah, give him a call. But he was very weak. You could tell when you talked to him. And anyway, so I went ahead and interviewed him. He was inpatient. Needed to get more information about his illness and the reported connection to the cat. And then I needed to get some information and phone numbers of household members and and who the veterinarian's office was where the cat had been treated. So got that information. He lived with his adult grandson, and who was a real character. He was a very good informant though. And anyways, called that household contact and got more information about what was going on with the cat and the case and etc. So based on all this, the cat had kind of been in and out of the vet's office. It had been really sick. It had this draining, really pussy wound. The case guy, he would have liked to have left the cat there because it was very sick. But he ran out of money to leave it at the vet's office, so he had to bring it home while it was still real sick and had this horrible draining wound. And he was trying to take care of this wound himself and squeezing the pus out of the pustules.
Did he wear
And
gloves
mind
at
you,
all?
he had this clean laceration that had been stitched, but he wasn't wearing gloves when he
Okay, that's
did
what I
all
was about to
this.
say, what's he wearing?
So he was really getting germs really in that laceration, stitched laceration,
Sutures.
Yeah,
Oh,
so it was just like a perfect setup. But anyways, called the vet's office to clarify what was going on with the cat, and so got detailed information. And their staff had been treating this cat without gloves on, which was scary. So we found out all these kind of really interesting stuff. And then we learned that the cat had passed away, and that currently it was in transport to the pet cemetery for cremation. So by this time we were at about 4 o'clock in the afternoon, 4 or 5 at this point. And the state epidemiologist, the head is, he's actually a veterinarian, Dr. DeBess. So he was really, it was great. Everything kind of fell into place. It was really cool. The state epidemiologist called the vet's office and talked to the vet in detail about what was going on. And then, so, because we didn't know, we knew we didn't really have people in the community that were from being exposed to the human, because he really wasn't contagious to other people while he was in the community. But the cat, there were people who were exposed to the cat, but we didn't, anyway, so the state epi, he determined that, along with Dr. Fawcett, they both discussed it. And we determined that, yeah, these people who were exposed to this cat should be considered contacts for prophylaxis. So anyway, but this cat was on the way to the pet cemetery, and the vet said, get a hold of them and don't let them cremate the cat. Tell them to bring the cat back to the vet, because the vet's gonna freeze it and hold it, and then we're going to arrange for OSU to come get the cat, So, and then, so we did that, called them all up real quick, and so the pet cemetery turned around and took the cat back.
After exposing themselves.
Yeah. Actually, they had the cat in their freezer, but they took it out.
Oh.
So called the pet cemetery, arranged for them to transport the cat back. Then, so everything was kind of settled down by that time. So, so talked to Dr. Fawcett and got orders from him to go ahead and phone in prophylaxis antibiotic for the contacts. So then we called so then I was calling the cases household, the veterinarian's office and the pet cemetery, and identified exposed people, provided education to them and got their information so we could phone in prescriptions in their pharmacies. So then we phoned in prescriptions to all the pharmacies. And then we did daily follow-up calls to the contacts for 7 days. 3 of the contacts, this is like in February, so there's lots of other respiratory illnesses going around. 3 of them had symptoms that required consulting with Dr. Fawcett, and all 3 people ended up not having any significant problems. Seemed like more like just regular URIs. One was in an airport on Super Bowl Sunday.
Yeah.
So they're like, me and my mom don't feel good.
Yeah.
Anyway,
Just very worried, probably.
yeah. So they were in an airport. So for a minute it was kind of like, but no. But none of the contacts were infected. So it was great. St. Charles identified 6 staff contacts who they treated and none of them were infected either. So all's well that ended well. So the challenges with the case was that day 1 was on a Friday, but we were able to complete all the actions in doing the thing and identifying exposed people and sending in their prophylaxis by 8 p.m. that day. So they were all able to start it right away. And one was in Florida. She had left the day before on vacation with her family. Luckily, there's cell phones, and so we were able to get a hold of her. But that was kind of tricky because, you know, it's an out-of-state pharmacy. It was late. By then, it was, you know, late in the evening, really late over there.
Was she in the urgent care? I did admit that he had gone to urgent care a few hours before the ER. But urgent care is a St. Charles urgent care, but not the hospital. And I forget.
That girl,
She was a healthcare worker, right?
yeah, but she was a 16-year-old girl who worked at the vet's office. Yes, and she'd been really involved with Cat.
Yeah.
So they were at like Disney World, so that was a little bit nerve-wracking because it was like, what if she has it? She's at Disney World. That would be horrible. But anyway, nothing turned out.
Me too.
And then the cat, another challenge was that the cat wasn't confirmed at the time of the start of the investigation, but did seem likely as a source of infection. So we figured all that out. That was what happened. So there you go. That's the story.
That's
So if y'all have any questions, let us know.
So what's the theory is the cat was out ratting or chasing rats or?
Yeah, that's.
both
Yeah, well, I
fighting?
mean, at first they kept saying, oh, you must have had fleas, you must have had fleas, but that wasn't, it really didn't seem like fleas.
Yeah,
Because the people in the house, they lived in a real interesting rural place. But like there was the cat was not known to have fleas, first off. And in the house, they didn't have flea bites. There was no people that lived in the house didn't have flea bites on their legs like you would think if people have fleas, you know. So there really wasn't, so we were kind of like, I don't think it's the fleas. But the cat was an indoor-outdoor cat and did hunt. So maybe it ate something, you know, maybe it ate a mouse.
They eat mice.
Yeah, and a
Yeah,
mouse or a
catch mice.
ground squirrel,
Yeah.
you know,
Great vector.
Some rumor of some sort of altercation. I think maybe initially the patient, the cat owner thought that the illness was related to some sort of injury or fight that he assumed there had been a fight. I don't think we really know. It was I think OHA says raccoon, the hospital notes twice say porcupine. But that's information they got from the patient. So, and I think it was unwitnessed, but you know, that this was an outdoor cat, a hunting cat. In fact, cats are the most common pet to carry Yersinia pestis, a plague, and spread it to their owners or their family. So, but way more common than dogs or other pets. Yeah. But they're usually hunting cats.
cool. So did you guys wear your full like plague uniforms with the mask and?
No, he was in full airborne precautions, not, you know, COVID had this, the term was, enhanced or something.
Oh, yeah.
You know.
Droplet.
Yeah, there you go. Right.
Enhanced
So
droplets, yeah.
so it wasn't that, it was mainly kind of just, I think it was, reverse flow. Reverse flow, once they determined he could have had pneumonic with pulmonary. So I'll make sure I know that answer. I guess it could have been droplet. I think droplet would be for any form of plague. You'd have probably a droplet in contact. Well, you have at least a contact precautions, but I don't know. So I guess, yeah, I probably went from contact in the very beginning. And then when my partner got involved, decided there could be the development of pulmonary that should either be droplet or airborne. So, you know, I'll find that out.
Sorry to keep asking questions. The prophylaxis is what? Levofloxacin for 5 days
The
or?
prophylaxis is doxycycline for this.
Doxycycline.
Yeah. Yeah, and I can't remember if I'll make sure I remember.
I think it's 7.
Okay.
So-
Remember. How many do we have? How many prescriptions do you think we?
We had 14, I think. Um. 14. 14 folks, yeah.
And, probably 2/3 were related to the vet clinic or the vet cemetery.
Most of them were the vet's office.
And the household, I guess, the grandson and.
The grandson, his girlfriend.
Yeah.
And then, two that, his daughters, well, his daughter and then his granddaughter who'd come in and it would like thoroughly clean this house and they didn't have gloves on. The cat had this pus all over the house. And so they came in and did all this cleaning and they were kind of like, oh, you know, I'm kind of scared. And I thought, yeah, okay, you know, makes sense.
Cat, when the cat died, patient had been in hospital about 36 hours when the cat passed away. So presumably grandson or the girlfriend, or the grandson, I don't know if he really did anything but play video games. So probably his girlfriend were taking care of the cat, at least cleaning up the house, you know, sort of makeshift vet hospital they ran out of their house, you know. For the cat.
Is there an estimate of like how much plague is out there? With wild animals?
Yeah, you know, the flea part of the zoonosis is really important. And so we think, and Dr. DeBess, I don't know if he's going to go into this for this presentation, what we're going to do for OREPI. I presume he will, but if you have pockets where there are fleas, and a lot of this is fleas outside of the house, so that's, I don't know how we determine that. So I think that the hatching cycles, which have to do a little bit with temperatures, and also how far the suburbs kind of penetrate into the rural areas. So they lived.
They live by Smith Rock.
Yeah, so they were in a rural
Smith Rock.
area, so northern Deschutes County. So that's hard to estimate that, but I think and then of course if there's fleas inside a home now, I don't think OHA or certainly Tri-County area Deschutes, or I guess it was a Deschutes case. We didn't really I don't think officially looked for fleas, but that would be an interesting thing to do. Some folks at OHA, including Dr. DeBess, and I think also my partner, were concerned that this lesion on their forearm might have been a flea bite. It's the only, there's no way you can, there was no flea in the wound. There were no other suspicious bites around that area. So the idea would be he was, doctoring or nursing his cat. The cat has some fleas too, and maybe, again, he was handling without gloves, a purulent abscess drainage. But perhaps there were fleas around too, and he had a flea bite, pretty close to where his finger was cut. So I don't know, but so that's a good question. I don't think we have a good idea. I think the key is, we'll bring this out, I think, in our presentation, at least Dr. DeBess will, I'm sure, is that we need to have a sort of higher degree of suspicion for this in terms of frontline providers. That it is something, if we're in the middle of Chicago or New York City, you're probably not going to see it. But if you have rural suburbs, you need to be thinking about this diagnosis. And there wasn't really, it was not really considered by anybody. Not until the lab said, hey, this gram-negative broad's you're sending a species, and then people started getting suspicious. So I don't think we missed the diagnosis very much. That's another question in the literature. Are there really mild cases that are subclinical that we never recognize? So.
Question, Kelly?
This is really interesting to hear. It's just a great case study, and like congrats to your team on like the contact tracing and surveillance and like all the measures taken. So I appreciate getting to hear that and learn about like the actions that your team took, and that feels like another good argument for like why we need really robust public health.
We're hoping if things go really well at OREPI that maybe we'll get invited by the Doge.
Oh, gosh.
Like this is like the story, like the non-story, like the non-sensational aspect of it is why we have and rely on public health. So I appreciate getting to hear that. And just a quick, can I get clarity on the timeline? Because I see so many articles about like the 2024 plague in Oregon, but is this just not in the media yet, or Am I confused on the timeline?
Well, this, I mean, the cat became ill middle, like second week of January and,
Last year.
last year, January 2024. Yes.
Oh.
So probably was, yeah, in the media, there's one case, I mean, I say cases or case presentations because it's the cat and the guy, the patient, but nobody else tracked this. I guess there could be other animals that, whether that porcupine or was sick as well as like, we'll never know, but yeah, so, but it hit the media very quickly and not everybody who wants to do an interview understands the sporadic nature. This is a rural infection that rarely is more than one patient at a time, rarely. I think probably all 90+% of those 18 cases over the past 9 decades were all individual cases.
Fascinating case.
And I just found a journal article that kind of answers your question. I'm composing an email right now to send you the link about the prevalence, looking at wild canines specifically. So Deschutes County is like a bigger dot than other counties.
Do they know if there's plague in the dogs, canines, or?
It was just looking at like coyotes, and it's
Wild, yeah.
porcupine was one of the animals on the list that had 0 prevalence.
It's raccoon, I don't know.
Bats have everything, right?
That's her. This is a great little case study. I was thinking in public health, we have our infectious disease. I'm thinking if afterwards we could talk about, do a little interview for a case study for public health and inside of an education setting. Yeah,
For students, you mean?
yeah, for students.
Yeah.
Because they have an infectious disease chapter. So, just think about that, just percolate.
I think it's really important for them to have an idea that they're reportable diseases, that it's not reportable just to talk about it with the press.
Right.
That we do things about, there's action items for all of these reportable diseases.
Yeah, it's like a really fun thing that they're just going to get into. Yeah.
So good.
I've got a great story from before I left Edmonton. So I ran a residency program in Edmonton, Canada. We were 30 residents, but we also had rotating interns at that time when we were in the hospital. And there was this rotating intern that had this implacable cough for like, I think it was January of 1993. This is really interesting, but anyway, so someone said to him, have you been tested for tuberculosis? And he went, no. So they did a sputum sample and he had thousands of tuberculosis bugs just in the sputum sample.
Wow.
So he got a laryngoscopy and he had laryngeal TB. Well, the guy had applied to multiple ENT residencies throughout North America, all over North America. So the CDC got involved and they had to find every passenger on every plane that the guy had flown on and get tested. The local public health department in Edmonton he was in a theater at a movie one night with 200 patrons. 157 of them had their TB test turned positive. So laryngeal TB is the most epidemic, and it's rare, right? But this is very typical of how public health interfaces. So that was in Morbidity and Mortality Weekly Reports in 1993. You can look that.
Oh, that's
And I thought in this little hospital, well, it's 350 beds, but some guy,
super
completely
smart.
unbeknownst, like you'd think you're an intern or a resident, but you think, oh, I still have this cough in my.
I should look into this persistent cough.
Yes, you should. Yeah. It could be pertussis.
It's a rare, and it's the most contagious type of active tuberculosis.
Yeah, so that was
More
a,
than cavitary pulmonary, yeah.
I mean, so these cases are really important, not that everyone's gonna be bitten by fleas, but
You get the idea.
yeah. What wasn't, there was another case here. Was it,
2012, I think it was.
was it?
when he was sick, he was in the ICU.
Yeah, that was the guy.
Septic, well, I think he had a small lymphadenitis, but probably more septicemic and secondary pneumonic, so he had.
Yeah, he was
pneumonia.
really sick, right?
Yeah.
He was from Pineville.
It's on dialysis.
Yeah.
And that was related to a cat too.
I'm telling you, cats.
So maybe,
The mice, I
I think we all
Yeah,
need
the mouse
can
and
you
the-
call me in a
mouse.
course of doxycycline? Just kidding.
think. Yeah,
But
yeah,
it's,
yeah.
I mean, the way public health interfaces with all these things is really important, right? Because, you know,
Okay. You know, so some of, what's nice about this is that I would say, you know, a good 3/4 of all of the reportable diseases are really quite contagious from person to person. But there's another quarter, or maybe 20%, that really aren't that contagious. Like it's valley fever, you know, as an example. You know, tick-borne infections, which are not transmissible person to person, but
right,
it's really important for us to be involved with environmental issues and with veterinarians, with the zoonotic infections, and look at trends of, you know, maybe right, because all these things are pretty much on the rise, whether it's, you know, cholera, tick fever, or Lyme disease, what have you. So, but those are really important. And we always interface with whether, and in the case of H5N1, you know, we've got, ODA. I know we work at agriculture, urban agriculture. So, so both state veterinarian, sometimes vector-borne organizations with the case of West Nile virus, and sometimes with the Department of Ag. We work with these folks a lot. And I think it's very productive relationship. And I think we learn a lot. And I think, you know, we tell patients where not to go. Another example would be, you know, harmful algal blooms, whether it's, you know, blue-green algae. And we have to monitor for that. We have to get the word out. We have to make sure it's safe to go back in the water. So we get to work with lots of different.
Yeah, and like the bird flu, we've had some cases of bird flu, and that takes a lot of different coordinating, you know.
We don't test any of the sick birds.
The
Really?
ODA,
ODA does all that.
yeah.
yeah, the state veterinarians work there, and then we get contacted, and then we have to do follow-up with the people who are exposed and monitor them, and so it gets interesting. Things like that, where it's animals and.
Central Oregon has a sort of historical events after this from this year, earlier this year, I think within the past 6 months, H5N1, so avian flu, bird flu, and what happened in Crook County was the first case of an infected pig.
Oh, right,
So,
yeah,
yeah, Crook County has that distinction.
cool.
But no human cases.
Species transmission, great.
Yeah, no human cases in Central Oregon.
But we did have one bird flu
Yeah.
that we had to follow up on, so.
And no measles yet.
Not Central Oregon, but other parts of Oregon.
Yeah, yeah. Oh, well, we can always hope. Sorry, I'm such a.
Looking for more to do.
Please.
Oh.
Well, I hope this was a good warm up for you both, because it's gonna be quite a bit bigger of an audience
No,
at the
you're right, Tom.
Oregon Epi Conference, so.
Yeah, thank you for letting us kind of,
Can I just make one suggestion?
Yeah.
Make sure your slides are readable from way back here, that's all, and maybe just the summary of the case presentation, you know, because the least number of like sentences and stuff you have a slide, the better, but that would help. But this is a great case. I mean,
Change the
It is
font
that-
on it,
that's-
the slides are still too basic.
Yeah. Those are good.
Maybe some graphics or visuals too. Here and there.
And
Sure.
a picture of you guys dressed up like this. Know this? And
Our former PHAB chair came to an event once with one of the old plague doctor masks and full outfit on. I think, or he came to a meeting even once.
Wow.
That was a while ago.
I don't think I'm gonna present like that, but,
Okay.
Yeah, thanks, everyone.
Thanks.
Thanks for the,
Oh, we're not gonna do that.
giving our cost of about getting.
Yeah, so we're not doing the strategic dialogue session.
Thank you.
You're having a strategic dialogue, but
No, I don't.
okay. But you're gonna strategize.